Hi everyone, welcome back to UWorld's Next Gen NCLEX review. My name is Samantha. I am a nurse here at UWorld and I'm so excited to be with you all today. So a lot of you guys may really be getting into the nitty-gritty. I know final exams are coming up for a lot of you, so we are going to cover a really important topic today, and that's going to be about electrolyte balance in the body. Specifically, potassium is what we're going to be looking at today. So we have a couple of questions sprinkled throughout just to test your knowledge as we go. And of course, we have our signature NCLEX style questions at the end so we can test out, challenge what you all learned today. We do take into account all of the topics that you all want to see, so please keep letting us know if you want to see more peds, more cardio, more OB, whatever it is. We are here to help you guys, so let us know the best way we can do that. You're also able to drop your questions, comments, and answers to today's questions into the chat. We encourage you to participate. We want this to be interactive. Nurse Jasmine is standing by moderating for us today, so she's ready to answer any questions that you all may have. So feel free to take advantage of that. This live will be on demand after we're done, so you're always able to tune back in. If you have to maybe pop in and out, you can't stay the full time, you are able to access it on our YouTube channel after we're done, which makes for a great future study reference. And as always, get that chat going. Let's start it off by letting us know where everyone is joining from. Who here is an international viewer? Who is a US viewer? It's always so cool to be able to see how far and wide UWorld reaches. It truly is worldwide. So with that being said, let's go ahead and get started. Now we're going to start out a little bit differently today. We're going to start with our test plan. So every now and again, we like to jump back in on this, but we've said this a few times throughout our lives in the past few years, but the NCSBN, who are the makers of the NCLEX, published some really incredible resources for nursing students to review before they take the NCLEX. A great time to review it would be before you start studying for the NCLEX so you can make a comprehensive plan. But one of these items is the test plan that we have displayed for you all. It breaks down the test into client need categories and activity statements. So I want you guys to just read with me what it says about electrolytes to really hit home why we're covering this today. But under the physiological adaptation client need category, which is essentially the category that covers all things disease processes, the activity statement reads, manage the care of a client with fluid and electrolyte imbalance. Then more specifically, it tells us that we need to know how to identify signs and symptoms of client fluid and or electrolyte imbalance. We need to be able to apply knowledge of the underlying pathophysiology when caring for a client with fluid and electrolyte imbalance. We need to manage the care of a client with fluid and electrolyte imbalance and evaluate the client's response to interventions to correct that fluid or electrolyte imbalance. So you can see just how prevalent this is throughout the test plan. We're going to use this to guide our discussion today. So let's jump back in on what on earth is potassium, what does it do in the body, what is its purpose. So potassium is pretty much the MVP of electrolytes. It is the Michael Jordan of electrolytes. It's an important intracellular ion, meaning it mainly lives inside of the cells, and its role is to control the fluid volume within the cell. So I don't want to get too far into the weeds, but we do need to take a quick visit back to chemistry class by talking about the sodium-potassium pump to really round out our discussion about potassium. So we're going to pull up an image of what a sodium-potassium pump has been characterized to look like in a cartoon-like drawing, but this pump is a critical protein. It's found on the cell membrane, and it's used to create the action potential of a cell, which pretty much is exactly what it says it is. It's slowly preparing the cell to be able to do its job, whatever that job may be, which is going to vary depending on what type of cell it is. So think of a pump like this. It's going to open to the inside of the cell first and grab 3 sodium ions, which are positively charged ions. Then the pump is like, okay, great. Full crowd, we got what you need. I'm going to push you guys outside the cell, but when I do that, I need to grab 2 potassium. The pump then picks up 2 potassium ions from the bloodstream, which is outside the cell, and pushes that potassium inside the cell. To note, potassium is also a positively charged ion. But the thing that's really cool about the sodium-potassium pump is that it forces these electrolytes into a space where there's a higher concentration. So it's using energy. This is active transport. This energy is called ATP, which is short for adenosine triphosphate. So sodium is moving from lower concentrations into the cell to higher concentrations outside of the cell. So it's swimming upstream, so to speak. And same thing with potassium. It's moving from lower concentration outside of the cell to higher concentration inside the cell, also swimming upstream. We call this active transport. The biggest takeaway from all of this is that the exchange of sodium and potassium is really important when it comes to influencing muscle function of the body. So we need these ions to move in and out of cells to get our muscles to work correctly, especially when it comes to cardiac muscles, skeletal muscles, and smooth muscles like those of our GI tract. So knowing that potassium should live in higher concentrations inside of our cell, let's learn what the normal range for potassium is. I want to walk through high serum potassium or hyperkalemia before we go to low serum potassium or hypokalemia, but we're not able to tell what that is until we know what our normal range is. So 3.5 to 5 milliequivalents a liter is where we want to be hanging out. That is our safe zone for potassium. Hyperkalemia would be any value greater than 5, and hypokalemia would be any value less than 3.5. But the good news here is that on the next-gen NCLEX, which was instituted in April of 2023, you no longer have to memorize reference range lab values. So those normal lab values will be provided to you on the NCLEX. You don't have to memorize that. You just have to be able to tell, is this inside that normal range or is it outside that normal range? But good news, you don't have to memorize them for the NCLEX. You may still have to memorize them for your nursing school curriculum, depending on where you go. But at least on the NCLEX, we get a little bit of a break. So hyperkalemia, let's go back to potassium. Let's talk about what causes our potassium to get too high and what happens in the body as a result. So causes of hyperkalemia or high potassium, in the big picture, we either took too much in or we're not getting enough out. Essentially, potassium snuck out of the cell and into our bloodstream. So this can look like a really large intake of potassium, maybe through diet, or if we were trying to replace electrolytes in hypokalemia, sometimes the medical team will overcorrect, putting the client into hyperkalemia. These are both examples of taking too much in. But more than likely, clients get hyperkalemia from impaired kidney function. So potassium is excreted through the kidneys in our urine. Things like acute or chronic kidney disease will decrease our GFR, which is glomerular filtration rate, essentially how much blood the glomeruli of the kidneys can filter. And this will cause hyperkalemia because our filters aren't working properly, we're not making enough urine, and we're not getting enough of that potassium out of the body. Medications can also cause hyperkalemia, things like a potassium-sparing diuretic or a spironolactone, or medications that reduce aldosterone secretion like an ACE inhibitor, which is a popular antihypertensive. There also are a few causes, conditions that can cause hyperkalemia. So let's start with DKA, first things first. This stands for diabetic ketoacidosis. In DKA, our body goes into a state of metabolic acidosis. So the pH scale is essentially a scale of hydrogen ion concentration within our blood. So the more hydrogen ions in our blood, the more acidic we are. Now, potassium and hydrogen have a direct relationship. So in DKA, we experience metabolic acidosis. So we have a higher concentration of hydrogen ions in our blood. Because it's a direct relationship, then we can also expect to have a higher concentration of potassium ions in our blood as well. Now, in the same vein as DKA, we can also talk about insulin deficiency and hyperglycemia. So DKA is extreme hyperglycemia. These clients can come in the thousands blood sugar. So all these start to fit together here. You may have learned that insulin moves glucose from our blood into the cells. It's going to give that cell energy to do whatever its specialized job is. It does the same with potassium. Insulin moves potassium into the cell. So if we have an insulin deficiencies or low levels of circulating insulin, we're going to have high levels of potassium outside of the cell because that insulin isn't there to wrangle it and pull it inside the cell. Now, conditions that cause cell destruction can also lead to hyperkalemia. Think of our cells as like balloons. Maybe we're at a party, and potassium is glitter or confetti that's being stored inside of that balloon. Things like rhabdomyolysis or tumor lysis syndrome burst those balloons. So rhabdo is essentially a breakdown of our muscles. So think bursting muscle cells. Sometimes marathon runners can get this after running a marathon. Since potassium is stored inside the cell, when it bursts, there's going to be this potassium confetti all over our blood, leading to hyperkalemia. Now, it's the same principle as tumor lysis syndrome. When clients who have a really high cancer burden and we start to begin that chemotherapy, those cells start breaking down or lysing, and that potassium confetti again explodes from that balloon when the cell gets lysed, and now it's all over our bloodstream, leading to hyperkalemia. Alrighty, I hope the party analogy is making this make sense. So what do our clients with hyperkalemia look like? What are some clinical features here? I want you guys to associate hyperkalemia with weak muscle problems. So it makes our muscles weak. Think of hyperkalemia this way. We know potassium should live inside of our cells, but if we have too much potassium outside of our cells, we could maybe assume that that potassium tank inside the cell is running low. We're running on empty. So instead of our cells being able to go 100 miles per hour per usual, they're only able to go 40 miles per hour, and they can't reach their full potential because that tank is low. We also talked about in the beginning the exchange of sodium and potassium is being really, really important when it comes to influencing muscle cell function. So question for you all to make sure we're keeping up: what is a really important muscle in the body, maybe the most important muscle in the body that's affected by hyperkalemia? What's our big worry here? What muscle are we most concerned about with hyperkalemia? Drop those answers in the chat, let me know. And you guys, per usual, spot on. Our heart. We are worried about our heart. And hint, hint, we're going to switch to an ECG strip slide, which is kind of a dead giveaway. But when we think about important muscles, the number one thing we should be thinking of is our heart. The heart is a muscle. Tie this all together. If a client has hyperkalemia, we're going to worry about changes to the electrical conduction of the heart, which will manifest on an ECG. Again, potassium is an electrolyte. It's going to disrupt the electrical conduction of the heart, hence the ECG strip here. So high potassium can result in high, tall, peaked T waves. We can see the absence of P waves. A good way to remember this is high K, or high potassium, can equate to high T, or a peaked T wave. It can also lead to prolonged QRS complexes. We can see heart block inevitably. When I think about weak muscle problems, I think about poor conduction, poor communication within the muscle itself. And that's how I think about heart block. Those signals just aren't quite making it where they need to go. So again, thinking about these weak muscle problems, clients with hyperkalemia can experience ascending paralysis, or paralysis that starts within the lower extremities and works its way up. It's similar to the pathology of Guillain-Barré syndrome. So knowing this, what are the complications that we really start to worry about here? We're most worried again about the cardiac system with fatal dysrhythmia. So if the hyperkalemia persists for too long without being corrected, our client can progress from those peak T waves to VFib and eventually all the way to asystole. Again, think about weak muscle problems, weak conduction, and weak communication. All that together really paints the picture of asystole. It's that total breakdown of heart muscle and the heart electrical conduction system. Alrighty, so we talked about these scary complications. Now let's talk about treatment. We're going to pull up a great table for you all. Again, any of these visual references you guys are able to screenshot, take it with you for your future study. But when we're looking at treatment, first things first, what do we want to do? Well, we want to monitor our electrolyte levels. We want to get our baseline, know where the client is starting out, and collect repeat levels per hospital protocol or provider order so we can make sure we're trending in the right direction. We also need to make sure these clients are on a continuous cardiac monitor. If ECG changes start to happen, we want to be able to recognize it and give meds that stabilize our cardiac cells like IV calcium gluconate does. So this is a priority, and I'm going to say that again, a priority. You may see this in a question at the end of today's lecture, because we need to stabilize that myocardial cell membrane. But important, even though IV calcium gluconate is our priority to stabilize those cardiac cardiac cells, it doesn't actually decrease potassium levels. So really make sure we know that even though it's our priority, it's not treating the underlying cause. So make sure you keep that in mind. But pretty simple, other than that IV calcium gluconate, we want to start to decrease our potassium levels by driving potassium into the cells or increasing potassium excretion. So speaking of driving potassium back into the cells, let's circle back to insulin. We said earlier that insulin helps to drive glucose and potassium into the cell. So hyperkalemia protocol typically involves some kind of insulin administration, even in clients that do not have diabetes. So we can give regular insulin IV. That's the only insulin that can go IV. That's also a big safety thing you're going to see on your NCLEX most likely. But we'll also need to add in some IV dextrose because we don't want to make our client hypoglycemic by also driving that glucose from the blood into the cell, because the insulin is going to take both that potassium and the glucose. So we give that dextrose and add that in so we don't become hypoglycemic. Other meds that help shift potassium back into the cell include sodium bicarbonate or bicarb, as well as nebulized albuterol. The onset of these meds is typically around 30 minutes. And the second way to decrease serum potassium would be to excrete it. We do this through the GU or the GI system. The thing about this is it's a little bit slower than our other options we talked about earlier. So we talked about potassium being excreted through the kidneys, so we can give medication like a potassium wasting diuretic, which could be a furosemide, which is Lasix. We can also give an oral potassium binder like sodium polystyrene sulfonate, which is Kxalate, which excretes potassium through that GI tract, but again, much slower mechanism of action. If our kidneys are impaired, we may need to start looking at dialysis. Essentially, that's a machine that takes over for the function of the kidneys to mechanically filter the blood back to normal levels again. Because kidneys can be impaired in like an AKI or CKD, they may be unable to do this on our own, hence the need for dialysis. Last but definitely not least would be nutrition. So if a client is hyperkalemic, they have too much potassium in the blood, we're going to avoid oral sources of potassium. We're not going to want to be taking more in on top of that hyperkalemia. So we're avoiding our potassium-rich food. So we are making sure we're not eating things like oranges, orange juice, bananas, cantaloupe, avocado, spinach, leafy greens, things like that. And we'll talk more about diets in the hypokalemia section, which, speaking of that, is a great time to switch gears. So before we jump to hypokalemia, I do want to bring up a quick mention about our commitment at NSNA. So we're going to bring up some pictures for you all here. But at the beginning of this month, the team took a trip to Columbus, Ohio. We went to the NSNA Mid-Year Conference. The National Student Nurses Association has 2 conferences a year. It's a fabulous organization, and UWorld is lucky enough to sponsor the NSNA. So we gave 8 hours of dedicated NCLEX review, as well as we were at the booth. We welcomed so many of you and got to meet so many of you at the booth with our question challenge. So if anyone is curious about the NSNA or UWorld and our partnership with NSNA, our social media channels are really great places to go for more information on this. We of course go to their 2 conferences throughout the year, but we also put on through the NSNA 6 virtual webinars throughout the year. We have wrapped up those for this year, but we will be back with 6 more next year. So if any of you guys are curious to be getting more information about that, maybe to join next year, we would love to see you. And a big congratulations to the University of Michigan at Flint for winning our question challenge. Congratulations. Someone is asking if this is AI. I promise I am not AI. I am very much real. Alrighty, so moving on to hypokalemia now. We're going to switch gears. So we're going to move on to a diet slide here. We're going to think fast with this diet slide. So quick reminder here, hypokalemia is going to be low levels of potassium in the blood, which is going to equate to less than 3.5 milliequivalents per liter or millimoles per liter. Now let's talk about our causes of hypokalemia. So big picture, think potassium going out of the body or potassium going into the cell is what's going to cause low potassium in our serum. So visualize a client and our starting point as the stomach or the abdomen. So think about anything going up like vomiting or maybe NG tube suction, or anything going down like increased urination or diarrhea. This can be from medications like a potassium wasting diuretic like furosemide, or conditions that cause increased urination like polyuria and diabetes or hyperaldosteronism. We can also think about conditions that shift potassium into the cell from the blood as another cause of hypokalemia. So think back for our treatment for hyperkalemia, which was insulin. Too much insulin can cause hypokalemia as well as hypoglycemia because it's pulling both potassium and glucose into the cell, meaning it's going out of the blood. Again, potassium and glucose have that direct relationship. So for hyperkalemia, we talked about metabolic acidosis. The opposite will be true for hypokalemia. We're going to be looking at alkalosis. So since hydrogen and potassium, we talked about them being directly related, when we have alkalosis, that means we have a low hydrogen ion concentration and we have a direct relationship, so potassium will also be low. Now let's talk about clinical features of hypokalemia. So what is a client in a clinical setting going to look like if they're hypokalemic? We're going to visualize too much potassium in our cells and not enough in our blood. That's what hypokalemia is. So if our cells have too much potassium, they're going to be jittery, they're going to be twitchy. I think about it if you've ever had too much caffeine. You know, I've only on a select few clinical shifts have I ever drank 2 Celsiuses, but this is what this reminds me of. That jittery, that energy, that twitchiness. Our heart is a muscle, we've already established that, and potassium really affects muscle conduction. And we're thinking about jittery and hypokalemia. So ECG findings can be things like premature atrial as well as premature ventricular contractions. Our atria and our ventricles are too excited. They're jittery and they're firing too fast. Clients can also experience dysrhythmias like VTach, VFib. So VTach, our ventricle is going way too fast. It's super glitchy. We can also see muscle cramps in these clients. Again, hyperkalemia had weak muscle conduction. Hypokalemia has that jittery, twitchy muscle. That sounds a lot like muscle cramping. Our smooth muscles of the GI system can also be affected. Clients can see nausea and vomiting. We can see decreased bowel sounds and even constipation as a result. So how do we treat hypokalemia now that we talked about all these really unpleasant complications? So as always, first things first, we have to get that baseline. We need to monitor electrolyte levels so we can make sure we're trending in the right direction. We're going to repeat collecting those levels per hospital protocol or per provider order. Now we need to make sure these clients are also on continuous cardiac monitoring because we already know potassium affects our hearts. And then we want to stop potassium from leaving our body. We need to put a big stop sign up here. To do this, we need to avoid potassium wasting diuretics like a furosemide. Maybe we'll switch it for a potassium sparing diuretic like a spironolactone. And we also want to stop GI losses of potassium from maybe diarrhea or vomiting or NG tube suction. So we might need to give like an antiemetic like an ondansetron, which is Zofran, or an antidiarrheal like a loperamide to stop these losses. Most commonly what you'll do to correct the imbalance is just by giving the electrolyte, so administering potassium chloride. Now when I said this, I hope a couple of you got a little bit nervous when I talked about giving potassium chloride because we know this is a very, very high alert medication. We have to make sure we are using our medication safety techniques when we administer IV potassium. So we never give this medication IV push. That is so important. I feel like that's the bread and butter, like you learned that first day of nursing school. This can be fatal to our heart muscle. Essentially, our cells are not able to navigate that quick influx of potassium, so it can be fast and it can be fatal. If any of you guys aren't familiar, a lethal injection is actually just an injection of potassium. So we give potassium either orally or we can give it through an IV piggyback at a slower rate. So if we're giving it IV piggyback, we're never giving it at a rate that's greater than 10 milliequivalents per hour. It is a vesicant, so we have to make sure we're monitoring that IV site closely. We always say potassium is spicy. We want to make sure we monitor for edema, erythema, and any signs of infiltration. Lastly is going to be a potassium-rich diet. If we don't have enough potassium, we simply need to get some more in via the blood or take some more in orally. We're going to increase the potassium in our diet. So these are all of the things we should be taking in hypokalemia, but avoiding in hyperkalemia. And when we talk about a potassium diet, we talk about think fast. High potassium foods include fish, strawberries, tomato. That makes up the acronym for FAST. Leafy greens, orange juice, oranges are also great sources of potassium. So great job, you guys. That was quite a lot, but we did it. It's now time to jump to our first question. So question number 1, the nurse is caring for a client with chronic kidney disease. The nurse notes tall peak T waves on the continuous cardiac monitor. Which of the following actions would be a priority for the nurse to take? Drop your answers in the chat. And our options are administer IV calcium gluconate to the client, teach the client to limit dietary intake of potassium, 3, request a prescription for oral sodium polystyrene sulfonate for the client, or lastly, prepare the client for placement of a temporary catheter for hemodialysis. Alrighty, let's see those answers. I'll give you a few more seconds. This is a bit of a longer lecture, so thank you guys for bearing with me. And also, while you're answering, maybe you're thinking it over, go ahead and drop your answers in the chat, and also let us know what topics you all want to see us present on. We've gotten a lot of requests for OB, maternal topics, peds topics, so if there's anything else you want to see. We talked a lot about ECGs, so if that's something you're interested in, please let us know. Drop it in the chat so we can make sure we're tailoring our content to exactly what y'all want to see. Alrighty, I see some critical care, some infection control. That's a great one. Infection precautions, contact precautions are so tricky. I feel like that's a hard thing to memorize. All right, so the good news is it looks like the majority of you guys got this answer correct. Option 1 was our correct answer. Way to go. Administering the IV calcium gluconate will be our priority. So when we see ECG changes with hyperkalemia, which will be those tall peak T waves, those prolonged QRS complexes, it's a priority for the nurse to administer the IV calcium gluconate to reduce myocardial irritability and protect the myocardium from potassium-induced dysrhythmias. This is our priority to protect the heart, but it actually does not have an input on changing the potassium balance. It doesn't decrease the potassium, it simply protects the heart, but it is our priority because we're always thinking about those ABCs. 2, 3, and 4. So 2 is incorrect because limiting dietary intake, that's going to take too long. Of course, we would want to, in a client with hyperkalemia, we don't want them taking in a lot of potassium orally, but limiting their potassium intake, it's going to take a long time for that to impact the potassium balance of their blood. This is not our priority. Remember, this is a priority question. I'm requesting a prescription for oral sodium polystyrene sulfonate, which is Electrolytes. This is going to cause excretion of potassium through the GI or gastrointestinal tract. It's much slower of a mechanism of action. It's going to take a long time to take effect. Something like giving insulin or the albuterol, nebulized albuterol, I always forget that word, is going to be much quicker. This is going to be a pretty slow thing, and it's not a higher priority than protecting the cardiac cells. And lastly, that hemodialysis, impaired kidney function often causes hyperkalemia due to the decreased glomerular filtration rate and that renal excretion of potassium. A hemodialysis catheter placement provides that temporary vascular access for acute hemodialysis. This may be performed depending on if the provider orders it as necessary, but we're going to do it after we give that calcium gluconate. Again, none of these options are more important than protecting the cardiac cells and stabilizing that myocardium. So option 1 was our correct answer. Way to go, you guys. Last question of the day, question number 2. The nurse is collecting data from a client with heart failure who is receiving furosemide. Which of the following findings would indicate the client is experiencing an adverse effect of furosemide? Is it 2+ pitting edema in bilateral lower extremities? Is it muscle cramps during ambulation? Fine crackles in the lung bases? Or increased urinary frequency? Drop those answers in the chat. Alrighty, what do you guys think? And a quick little look at our schedule for the next couple of weeks. But tomorrow we're back with a double live, 11 and 7 p.m. With mental health questions. Thursday we're back at 11 and 3 p.m. with our GU or genitourinary question drill, which will definitely include some things about glomerular filtration and the renal system, a lot of what we talked about today. And the following week is the week of Thanksgiving for all of our American viewers or anyone abroad that celebrates. We're actually going to be doing our greatest hits next week. So they will be pre-recorded compilations of one's about ECGs, one's based on pediatrics, and one is based on fundamentals. We take our most popular lectures and question drills that you guys all loved, and we put them together for our greatest hits, so to speak. So this week we're still live. Next week we're going to be doing greatest hits. I hope you guys tune in for that. We also did it over July the 4th, and we got some really great feedback on it. So alrighty, so the good news is a lot of correct answers, but it seems like a couple of you guys got a little bit confused on 3 and 4. So our correct option was option number 2. So option number 2, muscle cramps during ambulation. So this client is, they're saying they have heart failure and they're taking furosemide. What's an adverse effect of furosemide? So furosemide is not a potassium sparing diuretic. It is a potassium wasting diuretic. This is Lasix is what this is also known as. This may take off too much potassium, putting the client into hypokalemia. We know hypokalemia is that jittery, twitchy muscle contraction, which can lead to muscle cramps. So this would be an adverse effect of the furosemide because we're taking too much potassium off the body. 1, 3, and 4 were our incorrect options. So 1, 2+ pitting edema in bilateral lower extremities. This is a sign of volume overload that's associated with chronic heart failure like this client is in. This is what we're trying to treat with the furosemide, not an adverse effect of the furosemide. So we're trying to get some of this edema, get some of this swelling off the body with this diuretic. It's not an adverse effect of the furosemide. It's a sign and symptom of the heart failure. Same with option number 3. It's a sign of crackles in the lung bases, means we have some fluid in our lungs. It's a sign of volume overload, potential pulmonary edema. It's what we're treating with the furosemide. It's not an adverse effect of the furosemide. And lastly, increased urinary frequency. This is expected when we give a client a diuretic, they're going to diurese. They're going to get rid of some of that extra fluid. And they do this through the GU system. So therefore, they are going to be going to the restroom and urinating more frequently. This one would be expected. So again, option 2 was our correct option. I hope that makes sense to all of you guys. Thank you so much for joining. We're going to jump to our QBlank slide really quickly. For all of our users that are already using the UWorld product and have purchased, here's exactly how you guys can navigate on our QBank to more questions based on today's topics. And for any of you guys that do not have the UWorld product yet, here's a look into our QBank. It's just one of the many, many different ways you can filter our questions to focus on exactly what you're trying to improve and to learn more about. So screenshot that if you want more practice after we're done. In closing, thank you all so much for staying tuned. It's great to see you all. If any of our viewers today were at NSNA, don't be shy, jump in and say hi. It was so much fun to meet you all. We're going to be back tomorrow at 11 a.m. and 7 p.m. with mental health questions. Really looking forward to it. So y'all have a great rest of your day. Bye-bye.